Hello and welcome to this session on cohort studies and case control studies. In this session, we're going to explore the basic design aspects of cohort studies and the basic design aspects of case control studies. We're going to look at and understand when to use these study designs and analyze the strengths and limitations of both of these study designs. So, moving to our overview map of the different types of epidemiological studies, cohort and case control studies are analytical studies, and they are on the right hand side of this overview diagram. So what is the direction of research in cohort studies? They normally start with the exposure. This is the important thing about cohort studies. We measure and identify the exposures on a group of people, and then we follow these people up over time and then measure a range of health outcomes. We can have prospective and retrospective cohort studies, but in both cases the exposure is measured first. The participants do not have the health outcome that we are interested in, and then they are followed up and monitored yearly, usually over a number of years, 2, 3, 5, 10 and longer, and then over that time the key health outcomes are monitored. Cohort comes from the Latin cohors, which means warriors or the 10th part of a Roman legion, and it's defined as any designated group of persons who are followed up or traced over a period of time. So let's look at how cohort studies work. We start off with our general population, our wider population. We then choose our study population, which ideally should be representative and similar to the wider population from which they come. And this study population will have a range of exposures, high, medium or low, and they won't have the health outcome that we are interested in. Then within that study population, we identify the people who've been exposed or have high levels of exposure. And then we identify the people who are not exposed or have low levels of exposure. And then we look at the number of participants in our research with the exposure and who also later on get the health outcome. We then look at the number of participants with the exposure but who don't get the health outcome. Then we look at the number of participants with no exposure but who also get the health outcome. And then lastly, we look at the number of participants with no exposure and with no health outcome. And these participants are followed up regularly for a number of years. So the key elements to think about in cohort studies, and this is the same for all types of studies, is what are the aims and objectives? What is the hypothesis? This helps us to decide on the type of study design we want and also the size of the sample of participants that we will likely to need. We then choose the study population, the participants. We then define the exposure and how it will be measured. Remember, exposure comes first. And so we look at either the primary, the most important exposures we're interested in, as well as secondary exposures that we might also be interested in. We then define the outcome and how it will be measured, and the outcome comes later, so we measure the outcome after we've started measuring the exposure. We then define confounding factors. We will discuss what confounding factors are in a later session, and we'll look at how they will be measured. And then we follow the participants up at regular intervals over many years. So, how do we choose our study population, our cohort of individuals? There are three broad types of cohorts we can look at: geographical cohorts, occupational cohorts, and birth cohorts. Geographical cohorts are everyone living in the same geographical area, for example, a council boundary. So this could be a community with areas of high air pollution in it and areas of low air pollution. So it's one community. We take participants from that one community, but within that community there are areas of high air pollution, maybe near roads or motorways or railway tracks or airports, and areas of low air pollution, maybe near rural areas or agricultural activities. The second type of cohort we can look at is occupational cohorts, and we look at workers with similar types of job roles who have high exposures and workers with the same types of job roles who have low exposures. And the example we can give here are different types of airline pilots. For example, long-haul airline pilots who maybe pilot all the way to Australia and back, and airline pilots who just pilot in Europe, and look at the differences in, for example, radiation exposure between those two groups of pilots. We can also look at different types of office workers, or we can look at different types of agricultural workers. All of these would be classified as occupational cohorts. Lastly, we can look at birth cohorts, where everyone with the same date of birth is followed up over time. And one nice example of this is the Millennium Cohort Study, where everyone born on the 1st of January 2000 was included in this cohort and followed up over time. In one way, cohort studies can be seen as mimicking randomized controlled trial or intervention studies, where they follow up groups with high exposure and low exposure within one population. To make sure that the cohort, the study population, is similar to each other, we need to collect data on key confounding factors. This ensures that there are not other reasons why the people in our study are likely to get the health outcome. So, for example, if people smoke, they're more likely to get lung cancer, so we need to take account of that. Socioeconomic status, such as income and education, also have a bearing that people in lower socioeconomic groups tend to have higher health problems, and the people in higher socioeconomic groups tend to be healthier. We also need to look at selection bias. We need to make sure that the way we have selected the participants into the cohort study has been done in either a randomized way or in a way where we are not selecting for certain groups of people and not others. And usually we can use certain types of statistical methods to make adjustments later on, but once you have bias, you will always have bias, even with using statistical analysis to try and limit the impact of the bias. What kinds of exposures can we look at in cohort studies? We can look at occupational exposures: benzene, coal dust, electromagnetic radiation from computers. We can look at infectious exposures: immunization, Zika, malaria, hepatitis, for example. And we can look at social exposures like breastfeeding, physical activity, and dietary behaviors. We must develop clear criteria for what counts as an exposure. We must write them down, and they need to be very clear and without any ambiguity. Exposures can be binary, all or nothing. You have an exposure or you don't, or they can be graded. You can be high exposure, moderate exposure, or low exposure. Measurements must be done identically between the exposed study participants and the low or not exposed study participants. And the range of exposure measurement instruments that we have are self-completed questionnaires, physical measurements, either the person or the wider environment within which the person is living or working, and routine statistics such as specific census, cancer registries, health surveillance, data systems. Now, this information is collected now and is collected over time in the future as well. What kinds of outcomes can we look at in cohort studies? We can look at mortality, deaths. We can look at morbidity, whether someone gets a disease or health problem, or gets the symptoms or disability that is linked to a disease or health problem. And we can look at positive health, such as well-being. Again, we must develop clear criteria of what counts as the outcome, and measurements must be done identically between the exposed and the low not exposed study participants. And similar to exposure measurements, the instruments we can use are routine statistics. So rather than self-completed questionnaires, we often look at routine statistics to find out about health outcomes. We can do regular screenings and physical examinations, or we can also use self-completed questionnaires. And again, these are collected now and in the future as well. So what kind of calculations, what kind of measures of association can we make in cohort studies? We can identify the risk or the rate for each group of participants, both those who are exposed and those who are not exposed. So we start off with a population with a range of exposures, high, medium and low, but they don't have the health outcome. That's really important. So we've got our study population, which is a representative sample of the wider population. We have the exposed group of people and the not exposed group of people. And then we can work out the number of participants with the exposure and with the health outcome, the number of participants with the exposure but with no health outcome. And we can calculate the risk or the rate of the health outcome in the exposed group of people. And then for the not exposed people, we can find out the number of participants with no exposure but with the health outcome, the number of participants with no exposure and with no health outcome, and then we can again calculate the risk or rate of the health outcome in the not exposed group of participants. So this is where we're just looking at calculating and linking the exposure and the outcome for one group, the exposure group or the not exposed low exposure group. But that's interesting, but we actually want to know something more. And that is the next thing, which is measures of association where we compare two groups, where we compare the exposed group with the not exposed group. And for that, we do a ratio calculation. We do a risk ratio or a rate ratio because we are dividing the risk or the rate of disease in the exposed group and dividing that by the risk or rate of the health outcome in the unexposed group. So again, we start off with the population. And now what we do is we divide the risk of the health outcome in the exposed group of people and divide it by the risk or rate of the health outcome in the not exposed group. And that way we calculate the risk ratio, the rate ratio between the levels of health outcome in the exposed group compared with the level of health outcome in the not exposed group. And again, we follow the participants over time. So let's look at an example of this in action to help you think about it more clearly. So we start off with the population with a range of malaria exposures, high, medium and low, but with no anemia. And this population is a population of children. We have our study population of children, which is a representative sample of children from the wider population. So we have a group of exposed children exposed to malaria and a group of children who are less exposed or not exposed to malaria. And then we find the number of children with malaria and with anemia. And we find the number of children with malaria but with no anemia. And we can calculate the risk and rate of anemia in children with malaria. And we can do the same with the not exposed group of children. We can find out the number of children with no malaria but with anemia, and the number of children with no malaria and with no anemia. And we can calculate the risk and rate of anemia in children with no malaria. And we can do a rate ratio and a risk ratio of that, where we calculate the difference. We divide the risk of anemia in children with malaria compared to the risk of anemia in children with no malaria. And similarly, we could do a rate ratio. We could calculate the rate of anemia in children with malaria compared or divided by the rate of anemia in children with no malaria. And as always with cohort studies, these children are generally followed up over a number of years. So, what is a risk? So a risk is the number of participants who get the health outcome. In our example, that was anemia, and the number of people who are exposed at risk at the start of our cohort study. And that will be the number of children who were exposed to malaria. And the rate is the number of participants who get the outcome over the person years at risk. And we will look at an example of what person years at risk means. But it is a more difficult concept to understand. It's not an easy concept to understand. And that's why mostly all of us like to use risk rather than rate. But the advantage of rate is that it's a more accurate measure of disease occurrence than risk in cohort studies. So here's the example. What is a risk, what is a rate, and what is a person year? So you can see here we have 2 people who've died in our study. Our study lasted for 2 years altogether. And we had 7 people in our study. So that's 2 people divided by 7, which gives us 0.29. So there are 0.29 deaths a year based on what we found in this cohort study. However, we can see that some people died after 1 year, 1 person died after 1.5 years, and 1 person has been lost to follow-up. We don't know what's happened to them, and another person has moved away from the area and is not part of our study. So we can see here that the 2 divided by 7 is not an accurate representation of their risk of exposure. So what's a more accurate way of looking at this? More accurate way of looking at this is to look at the number of years that the people have been exposed. The 7 people that we have in our study, how many years were they exposed to that risk? And so you can see here we've got 2 years, 1.5 years, 1 year, 2 years, 1 year, 1.5 years, and 1 year. So if we add those up together, we get a slightly different calculation. We get 2 people dying, which is exactly the same as for the risk. But instead of the 7 people we have in our study, we can instead use person years. How many years were the people exposed? So when we add that up, overall, the 7 participants were exposed for 10 years. So it's 10 person years. The first person was exposed for 2 years, the second person was exposed for 1.5 years, and the third person was exposed for 1 year, the fourth person was exposed for 2 years, the fifth person was exposed for 1 year, the sixth person was exposed for 1.5 years, and the seventh person was exposed for 1 year. Adding that all together makes 10 years, so it's as if we had one person who was exposed to the risk for 10 years. And so the rate calculation is 2 divided by 10, which is 0.2. So the rate is, there's 0.2 deaths per person year. And you can see that the rate is less than the risk. And hence, that's why rates continue to be used, even though they're more difficult to interpret. They give a more accurate representation of the rate at which people are dying or getting a disease based on a specific exposure. So when we look at 2 groups of participants, we tend to measure, and when we're comparing 2 groups of participants, we tend to measure risk ratios and rate ratios. Risk ratios it's the risk in the exposed group and divided by the risk in the not exposed group. And the rate ratio is the rate in the exposed group in person years and the rate in the not exposed group in person years. Now, just a reminder, we went through what a risk and a rate was before, and that was here, where risk is the number of participants who get the outcome divided by the number of people exposed at the start of the study. And the rate is the number of participants who get the outcome, so it's exactly the same for risk and rate, the numerator, but the denominator is the different thing. Where for rate it's the person years at risk, not the number of people exposed at the start of the study. A common misunderstanding is people get confused and think that prospective studies happen where exposure information is collected first and people are followed up, and health outcome information is then collected afterwards. And that's totally correct, but they misunderstand that retrospective studies also do the same thing. The difference is simply that the retrospective cohort study already has data that they can use, but that historical data collected exposure information first and then collected health outcome information afterwards. It's just that we have all the information already. And just to explain that in a visual way, so if you have a retrospective study, we start where the circle is and the arrow is going forwards in time. So this retrospective study uses data that's already been collected in the past. And it has, for example, exposure information already collected first between 1990 and 1999, and then health outcome information already collected in the past, but it's been collected after the exposure information, generally a year or so later, from 1991 to 1999. So the information collected is still in the same direction. Exposure is collected first, and health outcome data is collected second. And that works the same way for prospective studies. The only difference is prospective studies generally start now, for example in 2020, and then you start collecting exposure information now, and then you collect this also into the future, and then you start collecting health outcome data. So for the exposure data, you might collect data from 2020 to 2029, and then the health outcome data, you start collecting that from 2021 to 2029. And again, the exposure information is collected first and the health outcome information is collected second. So what are the strengths of cohort studies? The biggest strength of cohort studies is that exposure is measured before the disease or health outcome occurs, and it's therefore unbiased. We can't fake or we can't tamper with the results. We have the right temporal sequence to establish an association, a cause and effect relationship. We can look at rare exposures. We can look at multiple health outcomes for any one exposure. And it can also help to identify biological mechanism of how the exposure and the health outcome are occurring. For example, is it occurring because it is changing the DNA in cells and hence causing a cancer, or is it some other biological mechanism by which the exposure is causing the disease or health problem? Lastly, we can calculate the population incidence rate for the health outcome, so we can work out how often the disease occurs in a population in a given year. The limitations of cohort studies is that it takes a long time to do generally. There are short cohort studies of a year and 2 years, but many of the key cohort studies generally are 5, 10, 15, 20 and longer. The financial cost of studying for so many years is also very high, and though it's good for rare exposures, it's not good for rare health outcomes, because we would need a very, 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 very large population to be able to do that kind of cohort study. So it's good for rare exposures, but not good for rare health outcomes. Like all studies, cohort studies are faced with selection bias and information bias. And there's two types of selection bias that are linked with the cohort studies. It's loss to follow-up. Because the cohort study happens over a long period of time, participants move, they don't want to take part anymore, or they are lost contact for some other reason. And this means the population in the exposed group or in the unexposed group changes over time. If the change is large and there's a big difference between the two groups, then the groups may not be representative of the wider population or with each other. The other type of selection bias is the original selection, because if the selection was not randomly selected, and usually that is the case, that it's not randomly selected, then the participants who are selected may not be similar to the wider population, and this may introduce a selection bias into our study. Because the aim of more studies is that we want to find information about the wider general population. We want to do a study on a small group of people, but we want to make sure that the findings of our study will apply to and be useful for the wider population from which the study participants have come from. The second type of key bias that affects more studies and that also affects cohort studies are information bias. And the key information bias is misclassification of the health outcome or the exposure. And what this means is that we have in some way not classified the exposure or the health outcome correctly. So if a person had a high exposure, we've classified them as having a low exposure. And if a person had a health outcome, we have classified them as having no health outcome, and vice versa. So have all the participants, including those who moved away or not in contact with the research team, been traced for whether they have the health outcome? If using existing sources of information, have these been accurately recorded? Has the exposure been accurately confirmed and again accurately recorded? And if this is a historical or retrospective cohort study, then have the possible inaccuracies in the data that we are using for exposure and outcomes, have we undertaken an analysis of where the inaccuracies might be so we can minimize the potential for misclassification of the health outcome or the exposure because the data has been collected 10, 20, 50 years ago. Two other examples that might be useful for you to think about is in terms of cohort studies and selection bias and information bias is, for example, looking at a cohort study of cholesterol and cancer. Some cancers can reduce the levels of cholesterol in the blood as part of their effects on the body. The cancer itself is causing the low levels of cholesterol. So we may find that we have selected participants with low cholesterol, assuming they don't have a cancer, but they may do. Now, the numbers of participants who are likely to be in this category is small, but it is important to recognize that it may be that the low cholesterol is caused by another health problem, i.e. that it's not a normal low cholesterol, but in fact linked to something else. And therefore, when we look at seeing whether this group of people get a cancer or not, we may find that the fact that the reason why they have low cholesterol may affect the final results of the study. Another example is hormone replacement therapy and breast cancer. Women on HRT are regularly followed up by GPs and to make sure that they don't have negative side effects from the hormone replacement therapy. Therefore, women on HRT are more likely to have their cancer detected by their GP because they are going to see their GP more regularly than women who are not taking HRT. So this may give the false impression that women on HRT are more likely to be at risk of breast cancer rather than that they are more likely to get their breast cancer detected by the GP early. So let's look at an example of a population cohort study. This is a prospective study. It's quantifying low birth weight, preterm birth, and small for gestational age effects of malaria in pregnancy. So the objective of the study was the association between malaria during pregnancy and low birth weight. The study was done near the Thai-Myanmar border at the Shoklo Malaria Research Institute. From 2001 to 2010, in a population cohort of prospectively followed pregnancies, we analysed all single births where the baby was alive, normal, and weighed in the first hour of life and had a gestational age between 28 weeks and 47 weeks, 41 plus 6 weeks. And in those babies, we then looked at where their birth weight and whether that was connected to the mothers having malaria. So women were screened for malaria by microscopy, and that result was then associated with the weight of the newborn babies. And the findings of the study were that malaria was associated with low birth weight, with preterm birth, and small for gestational age infants compared to mothers without malaria. The other factors that were also linked to low birth weight and preterm birth and small for gestational age effects on babies was low body mass index being the first pregnancy, hypertension in pregnancy, smoking, and the baby being a female or a girl baby. And these were associated with low birth weight and small for gestational age, but not with preterm birth. The study site was an antenatal program established in 1986, and you can see here some of the ways that they measured the babies and they diagnosed the malaria. So they diagnosed the malaria in a very specific way, and it's shown here. They were screened but using microscopy to see the red blood cells and whether those red blood cells were infected with the parasite. And in terms of the baby's weight, they used an electronic Saker scale to measure it with an accuracy of 10 grams, and they also list the model 336 or 376. And it was all infants born in the SMRU delivery rooms, and where staff had followed a standardized newborn examination. And the diagnosis of malaria was done using GEMSA, saying thick and thin blood films. And you can see here, malaria infections was defined by the presence of asexual stages of Plasmodium, the parasite, in the blood irrespective of whether the mothers had any fever or the symptoms of malaria. There's a really nice video which we will link to by Dr. Greg Martin, which is worth watching and which will further embed the learning about what are cohort studies and case control studies. Let's now move on to case control studies. Unlike cohort studies, the direction of research in case control studies is from the outcome back to the exposures. So we start the study here on the right hand side with outcomes and then move backwards in time to look at what exposures might have caused that outcome. We start with the outcome and then think about what kinds of exposures may have caused the health outcome. So this is the opposite to cohort studies, where in cohort studies, if you remember, we start with the exposure and then move forwards in time and then see if the person gets the health outcome. Here we start with the health outcome. We find out people who have the health outcome, for example, a cancer, and then we look back in time to see what kinds of exposures they had. And as the name suggests, case control studies have cases, which are individuals in a given population who have the health outcome that we are interested in. And we have controls, which is a representative sample of individuals in the same population as the cases, but who do not have the health outcome of interest. So these controls are people who could get the health problem, the health outcome that we are interested in, but do not have it, and they represent and are similar to the cases and similar to the wider population in every other respect, apart from not having the health outcome. The wider population that the cases and controls come from is often called the base. So let's look at an example of how case control studies work. So we start with the population here, and we find the people, the number of participants with a health outcome at a given point in time. There are cases. And then we find a number of participants with no health outcome at a given point in time, and they are our controls. Now, usually we tend to have at least one control for every case, and often we have 2, 3, or 4 controls for every case person that we have in our study. So we look back in time, we look at what exposures the cases had that might have led to that health outcome. And again, we do the same with the controls. We look at the controls and we look at what exposures they might have had and why they don't have the health outcome. And we go back over many years. So we could look back 10, 20, 30 years of past exposures. Just like cohort studies, and as with all types of epidemiological studies, the key elements are: what are the aims and objectives, the hypothesis. This helps us decide on the design of our study, what kind of study design we should use, and also the size of the sample of participants that we need. How many? Do we need 100 people? Do we need 1,000 people? Do we need 10,000 people to do the study and to get some useful findings? We then choose the study population, and in our case we choose cases, and we then choose controls, and then we define the primary outcome and how it will be measured first. So in this case, unlike cohort studies, we measure the primary outcome first, and then we define the exposures that we're interested in, and then we think about how we will measure them, especially because these exposures have happened in the past. And then, just like cohort studies, we look at identifying and defining confounding factors and how we will measure them. So what are the similarities and differences between cohort studies and case control studies? So at the top, they both have an aim and objectives. They both choose a study population, though in the case of cohort studies, it's usually one group of people with a mix of exposures. And in the case of case control studies, there are a set of participants who are cases who have the health outcome, and then separately we go and find controls who are people similar to the cases but who don't have the health outcome. Then for cohort studies, we define the exposure and measure it first. But in case control studies, we define the primary health outcome and how it will be measured first. Then in cohort studies, we define and measure the health outcome after we've measured the exposures and follow people over time, forwards in time. And then for case control studies, we define the exposure after we've measured the primary health outcome. And usually that's backwards in time. We're asking people to remember or to look at data that's been collected in the past about what kinds of exposures these people, these study participants, these cases and controls might have had. In both studies, we define confounding factors and think about how we're going to measure them. And in cohort studies, we follow up the participants over time, but in the case control, we don't need to follow them up. We can do the study today, and we could be finished in 3 to 6 months, while we get all the information from all the participants. So how do we choose and define cases? We again have to be specific and explicit about the criteria we are going to have to choose what is a case and what is not, what age group, what gender, time of diagnosis, time since diagnosis, and how are we going to define the health outcome? How is it measured? Is it measured because the person tells us that they have a cancer? Is it because we've gone and talked to their GP or hospital consultant or other doctor? Or is it that we have looked at medical notes? And the sources of cases usually is health surveillance data, for example, cancer registries. It may be death certificates. It may be pathology or specimen records for hospital inpatients and outpatients. Or it could be another group in the general population that we might be able to identify as cases. The health service is often a good place to get cases. And that's because, people go to hospitals and their GPs when they have a health problem. But it's only appropriate where the health problem leads to people going to and using health services. For example, stroke generally leads to hospital admission, so we can find people with stroke in a hospital or in either in inpatients or outpatients or in a GP setting, primary healthcare setting. So we need to make sure that where we look for cases is an appropriate place for people with that kind of health outcome to go to. So if the case happens to be something that people will go to a hospital or health service for, then that's where we'd go. But if it was some other place, for example, maybe subclinical levels of depression, where not everyone who has depression may go to their GP and certainly not go to a hospital, it was very severe, then we may use other ways, self-identified ways, maybe through a survey or some kind of screening program. How do we choose and define controls? We use the same criteria used as we use for cases, except that they don't have the health outcome. So we think about age, gender, and any other geographical area they live in, socioeconomic background, etc. The controls should be a random sample of individuals without the disease, but from the same type of population as the cases have come from. So this could be, for example, the electoral register. It could be people from a GP list. So, for example, if we found a case or a number of cases from, let's say, 10 GPs, then we would aim to make sure that the controls came from the lists of people who go to those 10 GPs, but who don't have that health problem, for example, cancer. Hospital source cases is also another way to do it, where you use the same hospital where the cases come from to find the controls. You look for people who are similar to the cases but don't have the health problem and choose them as your controls. They could also be relatives, they could be neighbours, or you could use or members of the same community where the cases live. So there's a range of different ways of identifying suitable controls, participants. One way we can make sure that cases and controls are similar is to do matching, where we match cases and controls by certain key characteristics. And the key characteristics are the potential confounding factors like age, gender or sex, place of residence, socioeconomic background, and there can be other things like number of pregnancies or the type of house someone's living in, and so on. And the advantage of matching is it increases the power and efficiency of the case control study. The only problem with matching is that by matching, you are essentially cutting that factor out. We can't analyze, we can't do any statistics, we can't look at that factor. So if we match by age, then we can't look at whether age is a factor in why some people are getting a health problem, a cancer, for example, while some people are not. Yet similarly, if we look at socioeconomic background and match against that, we can't then look at whether poverty has an impact or whether someone's getting, is that the exposure that is actually the bigger effect than the chemical exposure we might be interested in, for example, in relation to lymphoma, for example, as a health outcome. Matching controls, and especially when you're matching against a lot of different characteristics, can be difficult because you're now trying to find controls who are very similar to the cases but also are matching against a range of different criteria. So it can be difficult to find lots of controls when you start matching by 2, 3, 4 different characteristics. It can also be that we do too much matching. We match too much, and therefore they're so similar that we actually have no difference in the exposures, i.e. both the cases and controls tell us that they have the same set of exposures, so then we can't do any analysis, because what we want to find is that the cases have a different type of exposure, or they have higher levels of the same exposure, and the controls have different exposures or low levels of the same exposure, and hence we can then do some analysis and say, this is why the cases have this kind of exposure or this level of exposure compared to the controls, and that's why they're getting this health problem, this cancer, or some other health issue that we are interested in. So how do we define outcomes? It's very similar to cohort studies. We can look at mortality, we can look at morbidity, and we can look at positive factors like subjective, positive mental health and well-being. Again, we need to develop criteria for what an outcome is. And again, we need to do and measure this identically between the exposed, as in the cases, and the control group. So how do we define the exposure? We can look at occupational exposures such as benzene, coal dust, electromagnetic radiation, infection like Zika, malaria, hepatitis, or whether you have had an immunization or not, and again, social, breastfeeding, physical activity, dietary behaviors. So the exposures are very similar to cohort studies, and we're looking at similar types of exposures to what we do in cohort studies, except that we're looking back in time in case control studies to what exposures people had in the past. So how do we measure the exposure? Similar to what we did for cohort studies, you've got to have clear criteria as to what counts as an exposure. Again, you can have binary exposures, all or nothing, high or no, and we can have graded high, moderate and low levels of exposure. Again, the measurements must be done identically between exposed and not exposed groups. And the exposure measurement instruments that we can use, again, is similar to what we can use for cohort studies, except we generally start with questionnaires. We may do physical measurements, we may look at routine statistics, but this would have had to be collected in the past. So physical measurements and routine statistics would be data that's been collected in the past and that we're accessing now to look back in time. Self-completed questionnaires is often the main instrument used because we can collect the information now from the people who are taking part in our study. So let's look at an example of a case control study in terms of what kinds of associations we can calculate. We generally calculate the odds of exposure and hence the odds of a health outcome. So we start with the number of participants with the health outcome at a given point in time, the cases. We then get a group of participants with no health outcome at the same point in time, and these are our controls. And then we look back in time, we look at their past exposures, and we calculate the odds of exposure in cases. And we calculate the odds of exposure in the controls. And similarly, we're more interested not just in cases and controls, but in how cases compare to controls. So we take our population, we have our cases, we have our controls, we go back in time, we calculate the odds in the cases, we calculate the odds in the controls, and then we do a ratio. We compare, we divide the odds of exposure in the cases by the odds of exposure in the controls. We calculate the odds ratio between the odds of exposure in the cases and the odds of exposure in the controls. And in one way, the odds of exposure can be seen as a way of judging the odds ratio, the odds of the health outcome. We can convert it. We can go from the odds of being exposed to something to saying that's also the odds of being affected by that health outcome, because they link together. So let's look at an example here. So we start with the population, and we're going to look at a health outcome of lung cancer, and the exposure is cigarette or tobacco smoking. So we have the number of participants with lung cancer at a given point in time. We have a number of participants who are similar to the cases, but with no lung cancer at a given point in time. And we find that the cases are exposed to high levels of cigarette smoking, and we can calculate the odds of smoking in the cases, and then we calculate the odds of smoking in the controls, knowing that the controls are likely to have lower or no cigarette smoking. And then we calculate the odds ratio, which is the odds of smoking in the cases and the odds of smoking in the controls, which we can convert into, because it's almost essentially the same, the flip side, the odds ratio for getting lung cancer if you smoke tobacco or cigarettes. Now, we can't measure disease occurrence. There's no measures. We don't have incidence or prevalence. We can't measure those things like we can measure incidence in cohort studies, and we can also measure prevalence as well over time, because we've picked all the cases. We've picked people with the health outcomes. So we've picked these, so we can't measure how diseases occur. So what are the measures of association we can use in case control studies? A reminder, in cohort studies we looked at the risk and the rate. In case control studies we look at odds, and you'll see why in a moment. So the odds of the relationship between exposure and outcome in cases separately and control separately is the number of cases with the exposure divided by the number of cases with no exposure. And the odds in the controls is the same number of controls with the exposure divided by the number of controls with no exposure. And the reason we use odds is because we have chosen the cases and the controls. They are not a normal population, and therefore, because they're not a normal population, we cannot have a denominator. We can't say number of cases divided by all of the study participants that we have at the beginning, because the cases are separate and the controls are separate. So we cannot do a risk or a rate. And therefore, the only measure of association, the only calculation statistics we can do is an odds, and later on an odds ratio, which we'll talk about in the next slide. So the odds is the number of cases with the exposure divided by the number of cases without the exposure, and the same happens in the controls. number of controls with the exposure divided by the number of controls without the exposure. And then when we want to compare cases and controls, which is the more important thing we want to do, we want to find the odds ratio between the cases and controls. When comparing cases to the controls, then it's the odds of the exposure in the cases divided by the odds of exposure in the controls. Remember, the odds are number of cases with the exposure divided by the number of cases without the exposure, and the odds ratio is the odds of exposure in the cases divided by the odds of exposure in the controls. And let's look at an example to give you a better understanding of this. So here is a 2x2 table. So we have a group of cases and a group of controls, and they are exposed to something. Some of that group are not exposed. And so we have cases A who are also exposed to the thing we're interested in, and we have a group of cases who are not exposed. And that the odds of exposure are A divided by C. And we can do the same with controls. The group of controls who have been exposed and the group of controls who have not been exposed. Again, we can work out the odds of exposure in the controls. B divided by D. And there it is, A divided by C, B divided by D, that's the odds ratio. And A plus B is the total number of participants who've been exposed, who are in our study and been exposed, the number of cases and controls who were exposed. And C and D are the total number of participants, cases and controls who were not exposed. And then you have the total number of cases, A plus C, and the total number of controls, B plus D. And this is the total number of participants in our study, which is the cases and the controls. So let's look at an example with numbers and a few more specifics. So here we have cases and controls, and the issue, the thing, the exposure that we're interested in is smoking, tobacco smoking. So you have a group of people who smoked at some time or another, or are current smokers, and people who have never smoked. And what we find is that we have 120 cases who have smoked at some time, and we have 80 cases, people who have lung cancer, who have never smoked. So 120 people who have lung cancer have smoked in our cases, and 80 people who have lung cancer have never smoked. And that gives us the odds for the cases of 120 divided by 80, which is 1.5. And then we can look at the controls, and the number of controls who smoked at some time, it was 100, and the number of controls who never smoked is 300. And remember, the controls, neither group of controls has the health outcome lung cancer. It's only the cases who have the health outcome. And so that gives us the odds of 100 divided by 300. You can see we are not dividing by the total cases. We're not going 120 divided by 200, and we're not doing 100 divided by 400 for the controls. The reason being, this is not a natural population. We've created these populations, so that would not be the correct thing to do. So we can only use the odds. The people who have smoked divided by the people who have never smoked. As you can see, we have 220 participants in our study, cases and controls who smoked, 380 participants, cases and controls who never smoked. We had 200 cases of people with lung cancer, 120 of which smoked, 80 of which did not smoke, and we have 400 controls. None of them have lung cancer, and 100 of them smoked, and 300 did not smoke. And the total number of participants in our case control study is 600. And you can see here that if you calculate the odds ratio, you get an odds ratio of 4.5. And what you can say is people who have lung cancer have 4.5 times the odds of having smoked. 4.5 to 1 odds. And you can convert that and say, so if you smoke, you have 4.5 times the odds of getting lung cancer. This does not mean 4.5 times more likely, because odds generally overestimate the risk. So the risk is likely to be lower because this is not a risk calculation, it's an odds calculation. We cannot calculate the risk ratio because we are starting with cases, and therefore odds is the best thing we can do. There are some statistical reasons why using odds and odds ratios is important, and we will discuss these briefly in a later session. So what are the strengths of case control studies? They're cheaper and quicker to do than other types of studies, cohort studies and randomized controlled trials. They're generally slightly more expensive than cross-sectional studies, though it depends on the size and the duration of the cross-sectional study. But they're definitely cheaper and quicker than cohort studies and randomized controlled trials. They're very useful for rare diseases. Remember, cohort studies are good for rare exposures, but not for rare diseases. But case control studies are great for rare diseases and diseases with a long latency, where it takes a long time for the disease to appear. So it's cancer is a classic disease that we can look at through case control studies. We can also look at many exposures that are linked to that one disease that we're interested in, that one health outcome we are interested in. We can study exposures and other factors in detail, even though it's retrospective, and we will look at what the limitations of that are in the coming slides. But we can look at a lot of exposures and try and get as much detail as we can about them. We can also test new hypotheses, new ideas about what we think the relationship is between a disease and an exposure or a number of exposures. In that sense, it's similar in strength or in value to cross-sectional studies, which analytical cross-sectional studies can also be used to test new hypotheses, and so can case control studies. What are the limitations of case control studies? Like all study types in epidemiology, they are prone to selection bias and information bias. And the specific types of selection bias that it is affected by is the difficulty in choosing cases and control. It can be very challenging to decide what is a case and what is a control. And therefore, it's very easy for the case control study to have selection bias because we've chosen the wrong cases or we've chosen the wrong controls for those cases. And the information bias that affects case control studies is observer bias. Because we know the health outcome, because we know that the cases have a health problem, we can start looking for connections between the health problem and the exposures, and we may create bias by trying to create links that are not there. So we need to be very clear about what is a case and what is a control, and we also need to be clear about how we are measuring and describing and collecting information on the exposures. And the other problem we have is, of course, recall bias, because we're looking at exposures in the past, sometimes 10, 20, 30 years in the past. And so there's potential for recall bias, both in recalling by participants, the cases and the controls, but also in historical record. There may be changes in the way things are recorded. We may have better systems, better approaches, better monitoring equipment. So the historical records may also be prone to having a certain type of recall bias linked to the fact that the way the exposures were measured, it was not as accurate as it might be today. The other challenge for case control is, of course, temporal relationship, which came first, because yes, we start with the exposure and go back, but really we want to start with the exposure first and then move forwards in time to the outcome. So we can't be certain that there is a temporal relationship, a cause and effect between the exposure and the outcome that we are looking at. Unlike cohort studies, which are fantastic for looking at rare exposures, case control studies are bad and not good at looking at rare exposures. And lastly, we can't look at disease incidence because we've collected the cases, so we cannot find out how often a disease, a cancer, is occurring in a community. We can only do that with a cohort study. So one of the things that's very interesting, and I hope you have a sense of that, is cohorts are mirror images of each other. The strengths of cohorts are weaknesses for case control studies, and the strengths of case control studies tend to be weaknesses for cohort studies, or limitations of cohort studies. So let's look at a case control study. This is a case control study of occupational exposure to trichloroethylene and non-Hodgkin lymphoma. And the way they looked at this, the method they used was they looked at occupational histories for selected occupations from workplace information. They used an industrial hygienist to look at job specifications, and the way they did this, and I will actually go into looking at how they identified the participants, because that is the more interesting thing, is study participants were enrolled from 4 US registry areas: Iowa, Los Angeles, Seattle, and Detroit. And eligible cases were defined as 20 to 70 years of age, diagnosed between July 1998 and June 2000 with incident non-Hodgkin's lymphoma, according to the International Classification of Diseases for Oncology, without known HIV infection. The controls had no previous diagnosis of non-Hodgkin's lymphoma, and they were taken from a general population in the 4 registry areas by random digit dialing of people listed in Medicare files in those 4 areas, which were Iowa, Los Angeles, Seattle, and Detroit. And they were stratified or matched on the basis of age, sex, race, and the SEER area that the participants came from. So you can see, and what did they find? Well, overall, they found that the duration and intensity of exposure was not associated with non-Hodgkin's lymphoma, although there did seem to be some weak relationship between exposure to trichloroethylene and non-Hodgkin's lymphoma. But overall, the study did not find a good relationship between the two, between the exposure and the outcome. And just kind of following up on this, this is what happened in the study. Of the 2,248 eligible cases, 320 died before they could be interviewed, 127 couldn't be found, 16 moved away, and 57, their GP refused them to take part in the study. And of the 1,728 who were contacted, 1,321 responded. So there was about a 76% response rate from the people who were contacted, and a 59% response rate in terms of all the people that were potentially eligible to take part in the study. And it took them 12 months to interview 84% of the cases. And the number of controls were 2,409. Of which 28 died before they could be interviewed, 311 could not be located, and 24 had moved away. And of the 2,046 controls who were contacted, 1,057 responded, which was a response rate of 52% of those contacted, and 44% only of those who were eligible to be controlled. So you can see here how you can lose a lot of people over time for whatever kind of study you do. People can drop out or not take part, and ideally you would want them to take part because they're eligible to take part. Okay, I hope you enjoyed this session. We'll do some practicals on cohort and case control studies in the teaching session, the apply session. I look forward to seeing you then. Bye-bye. One thing to note is there's some interesting videos around, and these two are worth watching. We will link them in the Blackboard